what we're going to do now is go to page 48 in your manual, and we're going to look at how to use the information path that you just accumulated over the last day and a half. You had 4 or 5 tests yesterday, you had 2 today, and what are we going to do with all that information? We're going to put you in a position to see if it changes the outcome of those functional tests. That's what we're really doing right now. And to change the outcome of those functional tests, we got to be able to set up the board, the Monopoly board, and put pieces on it that we can all play. So we got to get you into a position to do so. And that's what we're going to start off with on page 48. It's a wonderful little algorithm. I'll take you through it. The very first question is the one that we started off really kind of yesterday morning when Carl was here and we were talking about the need to find hamstrings. Can you adduct? That's the first thing that's coming up on that screen. Treatment considerations. Could your patient adduct? Can they adduct on the left? Can they abduct on the right? If you wanted to write that down. Can they adduct on the left? Can they abduct on the right? So you could have put up there, can they adduct on the left, followed by can they abduct on the what? Right. So regardless of which test you would use, you now know the test that will tell you that information. If they say no, they cannot adduct on one side, then you go to your graph and you say, okay, if they cannot adduct, we need to consider this thing called reposition, which is what we're going to demonstrate right now. So we're going to reposition them. It says they cannot adduct. We're going to reposition them. And I'm going to stop this slide. So just remember where you were. Circle the word reposition. We're going to come back and then recheck if they can reposition after we reposition. We're going to check if they can adduct, or abduct after they reposition. So I'm going to skip a number of slides here. Just hang in there. We're going to skip these slides. Jen and I decided it was a lot easier to do this than to restructure your, and we're going to go all the way over to this repositioning stuff. We're going to skip all this. Jen, is it coming up? Here, right here. Let's just start right here. And we're going to do a 90-90 hip lift on page 16. Everybody go to page 16 in the appendix, Jen. And
page 49 in your book will show that the biceps femoris is to reposition left side up.
Right, and you're going to help me out. Yeah, I just skipped everything. We're going to go right to where it says bicep femoris. And don't worry about what the title says up above. Let's just look at 90-90 hip lift. Dallas, do you mind if I could borrow you for this one? Come on up. We're not repositioning anything right now. I mean, we're not treating anybody right now. We're just repositioning. We're going to give you a reposition. And Dallas, would you help me? I think it's still too close to the screen. Can we move this table? Hold on just a second. It's a heavy table, Dallas. So there. We okay, Don? That'd be okay. All right. So I'm going to have Pat. You volunteered today to be my reader. Would you mind? So if you go to that page, if you would start at the very top, read. Then we're going to do a 90-90 hip lift, and we're going to do it for the left hamstring. If you could read that, Dallas and I will follow you, okay? It's not going to be up there. We will not have any wording up here. It's just going to be in your manual. So you're going to read it in the manual, okay? Dallas and I will listen to you. What's that?
You test him first.
I'm not sure it's important right now because we're not treating anybody right now. I just want you to learn how to do this, okay? I don't really, Jen will take, if we do, we're going to go, it'll take longer. So all I want to do right now is make sure you understand 2 or 3 90-90 hip lifts, okay? And then, do we have another lab? Okay. Then what we'll do is we're going to do the 90, and then we'll check to see who you got, what you got. You'll check, you'll do an adduction drop test, and then you'll do a 90-90 hip lift, and you're going to see what it does for that individual, okay? I don't really want to know what he's looking like. I didn't go around the table. I didn't know if you can adduct or not. That's not the intent right now. Let's learn the procedure, just like we did with everybody else. Let's learn the test. So then you can go back and apply this to see if it works, okay? Let's learn how to do it correctly. Pat, let's learn how to do it correctly. I've got a board up here. It's got a ledge. You don't need this. We're just protecting a wall. Any wall will work. You just got to make sure that the feet on the wall don't allow slippage. So sometimes no socks, just flat feet, nice, damp, flat, boldy feet will work just fine. Sometimes you need a little grip, and you put a shoe on, okay? So he's going to put his feet up here. This heel counter in his shoes and this ledge is going to give him a surface to push down on, okay? So he's going to put his feet flat up there. Pat, are you ready? What's the first thing? What does it say?
Number 1, lie on your back with your feet flat on a wall and your knees and hip bent at a 90-degree angle.
Done.
Number 2, place a 4 to 6 inch ball between your knees.
Okay. Almost done. Thanks, Jen. There it goes. Now, right away, I just placed it there, Mike. Right away, he had to use what muscles to hold that ball from falling down? His ischial, his adductors. It's all adductors, absolutely. And anterior glute median. Okay. If he's putting his feet on the wall, it would be hard, Lydia, to turn on those beautiful TFLs of yours on. Do you follow me? Because his feet are on the wall. I'm going to have you drop the ball. Thank you. He just dropped that ball. To drop that ball, I didn't turn to you. He did not turn a muscle on. He just let go. Do you mind if I share a little story right now using Sheila? Sheila, we were talking at the break how important it is to have what under your feet? The ground. How tall are you, Sheila?
5'1".
That little 5'1" body is always going to have her TFLs on if her feet cannot fall on that ground. Her little body in this 90-90 chair position. I see Dallas sitting in a chair. Do you guys see Dallas sitting in a chair? This is called the ground. You see Dallas is on the ground right now. He has a ground for his head to recognize. His mind is saying, there's my ground. But if I take his feet off that ground, all his myokinematic activity just dropped off. His knees just went away. All your myokinematic activity would be shifted to other places on your body if you didn't have your feet on that what? Ground. So wouldn't it be kind of important to keep your feet on the ground when you're in a seated position, at least 1 or 2 throughout the day? So if you don't, you're now going to pull your spine forward with psoas muscles and iliacus muscles. Does that make sense in this course? TFL muscles, rectus femoris muscles. What do those 4 muscles do to the lordosis of your back? Increase it. You're going to push your butt on that chair without a ground by pulling the spine apex at L2 forward with those 4 muscles. And the rectus femoris does not go to the spine, but it pulls on the anterior superior iliac spine. So all 4 muscles were going to be engaged if I take him off that wall, because he has no wall, Katie, and he'd have to hold his feet up off that wall with those 4 muscles. Dallas, take your feet off the wall. Welcome to those 4 muscles. Feel those 4 muscles? Can you imagine working 8 hours, 14 hours a day with those on? Put your feet on the floor. Oh, Dallas, doesn't that feel a lot better? I think we really go way too fast with all this. I really do. Myokinematically, it's important for you to sustain active, not passive, neutrality with your feet remaining on the ground at least some time, which means one can leave, one should stay. One can come up, the other one should stay. I'm going to put a ball between his leg to activate and inhibit to deactivate the 4 we just talked about, and now physically ask him to inhibit those 4 because he's turning on muscles now that's providing internal rotation immediately when I put that ball there. And I never asked him to squeeze. I said, let's put the ball there. That myokinematically brought him to life with internal rotation that he senses through Dallas that wall. Did you feel those? Did you feel the big toe? Drop the ball. Did you drop your big toe? Did you drop off the big toe?
Yeah.
Could you find your big toe?
Sure.
Put the ball between the feet. Did you see how you went towards the big toe?
Mm-hmm.
So he's now got a heel and big toe, and now I know he's got good contact for reference. What's the next one say? I think we just got to go this slow. I'd rather put emphasis right now, Jen, what are we trying to do? What are we going to do with that person that has a 2 and needs a what, everybody? A 3. What are we going to do to get the 3? Let's not take this lightly. I thought about it last evening. Huge. We're taping this. Big. Big. Right here. Pat, second one.
Inhale through your nose and exhale
Stop.
through your mouth.
Stop. I'm going to do that a lot. What did I say yesterday about posture restoration? There's always going to be what? A breathing technique. This is a myokinematic course that involves a breathing technique. Inhale through the nose, holding that ball, resets that system. I can tell you right now, if he holds that ball and inhales, I don't need to worry about a left hamstring. He just probably already what? Reposition himself with the diaphragm that's in a position that's no longer stabilizing that spine. So I won't go to that course, but I want to make sure in this course you understand that there's an inhale with a ball between your legs. Whoa, big. Katie, inhale with an adductor on. Big. Inhale with a medial hamstring on. Bigger. Inhale with a glute max that's holding you on the right side in position. Biggest. Man, that got big fast. Should we do that again? Inhale with a ball between your legs. Big. Inhale with you squeezing one medial hamstring into that ball. Bigger, because you picked a side. And then what's the biggest? Contralateral ER from a big what? Big what? Glute max for hold control on the opposite side. You just sealed the entire course right there. Every technique from this point on is going to have a little bit of that in it. Every technique from this point on is going to have a little bit of that in it. I can't imagine a technique in your manual that's not going to have one of those things in it. Pat, so I stopped you, and I didn't mean to intentionally hurt you, but do you understand how important that is?
Yeah.
Whew. Will not fail if you can do that. Now you can finish it off. Inhale through the what?
Inhale through your nose, exhale through your mouth.
Pat, of all people, that makes sense to you, doesn't it?
Absolutely.
Inhale through the mouth is not going to give you bigness. Inhale through the mouth means you're going to substitute with extension, not from that wall. In fact, if he inhales through the mouth, he loses the wall. So I think we really need to talk about PRI myokinematically. So what's the next one say?
Performing a pelvic tilt while you're breathing this way so that your tailbone is raised slightly off the mat.
Now that may be the entire program right there. So I may have Dallas just inhale through the nose, exhale through the mouth, without losing that ball. He didn't drop the ball, so Lydia, I didn't even have to have him squeeze the ball. Do you feel the ball there? Inhale through your nose. Did you feel that ball get tighter? Mm-hmm. Blow out through the mouth. You didn't drop the ball. Inhale through your nose. Blow out through your mouth. Inhale through your nose and feel the ball. Now go slow. Inhale through the nose, deep inhale, and squeeze the ball. Blow. That was called a posterior pelvic tilt. He just did a posterior pelvic tilt on exhalation. Did you feel that? I didn't have to tell him to do a posterior pelvic tilt. I want this on tape. Don't cut this part, Jen. I didn't ask him to do a posterior pelvic tilt, but I asked him to do a posterior pelvic tilt by exhaling through his mouth after he just inhibited the hip flexors by the way he breathed. So if you're asking a person to do a posterior pelvic tilt and they're not breathing this way, you're just missing the boat. I could get everybody up here right now and do that, and you'd all be right now what? Neutral. But then we didn't get the left hamstring, Chad. So I know everybody out there is not going to do it that way. So I know I can't trust everybody doing it that way, because the minute you say posterior pelvic tilt, you're asking the patients to do a posterior pelvic tilt. And you forgot on how to instruct them to do it by breathing accordingly with their nose and their mouth. And the reader will tell you that's a cardinal sin, maybe a mortal one. Okay, right, Pat? Maybe?
Absolutely.
Maybe?
Maybe.
Okay, let's keep going.
Keep your back flat on the mat. Do not press your feet into the wall. Instead, dig down with your heels.
Stop. Problem number 600. Everybody thinks that they got to push a hole through the wall. All you got to do is keep your feet on the wall so they don't what? Slip. You won't slip if you dig your heel into that wall. That's called heel contact. That's called initial strike. That's called hamstring activation. That's called hip flexor deactivation. Done. Let's not cut that. Let's make sure we got that, because this is an inhibitory technique. And then what are we going to do, Pat?
You should feel the muscles in the back of your thighs engage.
Let's see if that's true. Take a breath in through your nose. Blow out all the air. Good. Did you feel your muscles did you feel your heels go down when you blew out? I mean, don't do this, be honest. Did you feel them?
A little bit.
Okay, do it again, in through the nose. Keep blowing, keep going, keep blowing, keep blowing, keep blowing. Can you feel that? Do you feel that? If his heels are engaging, is he doing an anterior pelvic tilt or a posterior pelvic tilt? He's doing a posterior pelvic tilt, because if the heels are engaging, his hamstrings had to kick in. I didn't say kick in your hamstrings, Lydia. I didn't say push down. I said blow. If he says, you know, I don't feel my heels kick in, Lydia, I feel my toes when I blow out, stop the boat. He's rocking all over the place. He doesn't have himself. He doesn't have hole control. Stop it. If you tell him to do a posterior pelvic tilt to get that, I'm not sure we're helping him a bit. If you tell him to dig harder, I'm not sure we're helping him a bit. Because if you use the word harder, he just substitutes greater. But if I say to him, can you please sense your heels and your feet on the wall as you raise your knees up a little bit, I'll bet you will help him a lot. Because if he says, no, I don't feel my heel, well, then what would I say? To feel your heel, could you blow out the air and raise your knees a little bit? Why don't you write that down? If I don't have his heel at that point, I'm not going to ask him to do a posterior pelvic tilt. I'm going to ask him, could you raise your knees a little bit? And you just gave him a posterior pelvic tilt. Here's the problem. The country is posterior pelvic tilted minded, literally. Could you give me a posterior pelvic tilt? Well, yeah, I'll try. I think I can get it. Because their emphasis is on the pelvis, and they don't even know what posterior means. If they're doing a posterior pelvic tilt with their breathing problems that they've had, you've got nothing. So be careful with the word called, this is a myokinematic course. So be careful with the posterior pelvic tilt. If you have to put your hand on them and guide them, you know we want you to guide them in a posterior pelvic tilt. If it takes that, do it. But what I'm trying to get across right now, you're not inhibiting enough if you have to do more for them. This is total inhibition so far, Pat. We are not facilitating. We are inhibiting right now. We are inhibiting, so he doesn't have to work for this 90-90 thing that's coming up. So, Pat, what's the next sentence say?
You should feel the muscles in the back of your thighs engage.
Okay, so look, we're going to keep going on because we established that. Okay, and what's the next sentence say?
Hold this position while you take 4 to 5 deep breaths in through your nose and out through your mouth.
That's called a 90-90 hip lift. Everybody understand what you just, right there, circle that. That's called a 90-90 hip lift. 4 to 5 breaths in and out through your nose and mouth. That's called a 90-90 hip lift. I see balloons flying around the country, and we love it, by the way, because they're doing 4 to 5 breaths. That's called a 90-90 hip lift. It wasn't because they were doing more work with their hamstring. They were doing more work with what, Chad? Their breathing. They were getting their hamstrings to work by deactivating muscles they pull air in with. Rectus femoris, psoas, iliacus, TFL. You want to write that down? That's how they are pulling their air in. Make sense? Got to come to Jesus talk right here, right now. Why are we doing 90-90s? They blow out that air, and those 4 muscles are deactivated, Pat. So the only way they can breathe in the next one is with a hamstring, an abdominal wall, and a diaphragm. Write those 3 down. And now my friend Carl would say, I have his hamstrings. This is a beginner course, right, Gibby? This is that first time you took this course, this is what you got, right? And you've been building off of it since then. This is a hamstring course, totally built on inhalation I's. Inhalation, inhibitory, and internal rotation. Write those 3 I's down. That's a 90-90. Giving this a lot of press. Giving this a lot of press, folks. Christy gets this. Inhalation, inhibition, internal rotation. That's really important for the colleagues of ours out there doing it. And we call that in a loose pack position called what, everybody? 90-90s, which we established yesterday. Pat, keep going. Didn't think we'd get this much mileage out of a simple technique, did we? But this carries out through everything we do from this point on, which I won't hit again. What's the last 2 words say?
Relax and repeat 4 more times.
That's it. That's called a 90-90 hip lift. That's a hip lift. I didn't see, can you do me a favor, Dallas? Raise your knees way up in the air. That is not a 90-90 hip lift because he's holding his breath. You feel that, Dallas? Can you say the word back? Because you feel it. Do you feel that back?
Yeah.
That is not a 90-90 hip lift.
Ron, could you go over the difference between people that try to brace and fill their abs compared to just exhaling and fill their abs?
Yeah, and thank you, Chad. The abs literally need to be off for you to do this correctly in the beginning. Because if you brace with your abs, if you try to lift with your abs on, most people, if you tell them to do a posterior pelvic tilt, Chad, what's the first muscle they're going to use to do that posterior pelvic tilt with? Their abs. Because they've been instructed to. Tighten up your abs to do a posterior pelvic tilt. But their spine is still not regulated. So they're using their abs on a spine that's still into too much what? Extension. They stabilize the spine, but they're not using the 2 legs to relax the spine. So I like jelly belly. Let's see if you can give me a little jelly belly here. Take a breath of air in through your nose. Blow out the air and squeeze that ball, as you do. Good. Did you feel your heels go down into that mat? Okay, down in that thing. Now, what I want you to do, the next time you take a breath in, breathe in, don't let go of that ball. Now, pull it in. Blow and start to raise by pushing your knees up in the air a little bit. Tuck that. Very good, right there. Do you feel your hamstrings kick in? I'm done. Jelly belly. Should we show him what happens with Chad when we don't do that correctly? Take a breath of air in. I don't mean to tickle you, Dallas. Breathe in, blow out. Push your heels hard on that mat. Good. Got it? Take a deep breath in. Did you feel those abs get tight?
Yeah.
That's not going to work. Because nobody told him how to do this correctly. You told him to push his heels down hard into this, which is why I hate these. Because technically he shouldn't have to have that ledge. You understand why? Because he's putting enough pressure on the feet to get the job done. Let's see if it changes. Are you ready for this one? Forget this. Come off that. You're off of it. It's not there. Do you feel it? Just you and the wall and the floor. Oh my, don't die. Here we go. Take a breath of air in. Blow out all the air. There. Do you feel the floor more? That's called the floor. Do you feel the floor more? Dallas, correct? Take a deep breath in through your nose. Blow out and feel that floor more. Pushing that floor. Feel that more? Good. Take a deep breath in when you're ready. Blow out. Feel that floor more. I don't mean to tickle you, but Dallas, do you feel much looser you are right here? Chad, thank you. This guy is now feeling his what? What are you feeling? And he just opened his pelvis up. He opened his posterior mediastinum up. He opened things up in his cranium. He opened up everything in his life because he maintained IR as he inhaled and as he what? Inhibited. I just shut off his abs. I just shut off his hip flexors. I just shut off all the muscles that he substitutes with. And the only thing he's got left is a hamstring, a glute, and a diaphragm. which I will give him abs when he has to put a balloon in his mouth to push the air out and then not let the air come back. That's when you put the balloon in the mouth. Now I can give him a balloon, and now I've got hamstring, glutes, and abs and a chest wall called the diaphragm. But until you get this, the balloon may not help if he's extending his what and doesn't have his what. But the balloon probably is going to help 90% of those patients out there because they're going to inhibit things called hip flexors with the abs engaging. But putting a balloon in the mouth doesn't automatically mean you're going to get this. Does that make sense? So I'm a little concerned. Balloons are great. We love them. We see them everywhere in the country, and we know where they're coming from. But I really got to remind you what we're doing the balloon activity for is to co-activate an abdominal wall, eccentrically, if you will, which is another course. This course is saying before you even get into that, let's reel in inhibition and make sure that we got these hamstrings working for our patients. Because these hamstrings are controlling this whole lower quadrant. I think we killed that. Are there any questions about what I just did? Any comments about what I just did? So Pat, if we go to the next slide.
I just want to clear up, I think before you had to do this technique, you said repositioning technique to get from level 2 to level 3 on the Glasgow Excellence test, but it would actually be level 1 to level 2, because
Okay.
if you cannot adduct, so you're not neutral, you wouldn't be able to get a level 2.
Thank you for the
If you
clarification.
wanted to, just wanted to clarify
I
that.
appreciate it so much.
Ton of phone calls.
Appreciate it, Jen. Keep that up, please. This is a night, Dallas, are you okay? Yep. 90-90 hip lift with medial hamstring. Without Pat reading it, Pat, thank you. That's all we're going to do now. You did a great job. Thank you. Let's just go to, Dallas, you can't see this. Why is this a cool technique in the 90-90 repositioning technique? What's going on now? What's the muscle we're going to kick in? What isolation are we going to do a little better? Remember, you can't really isolate anything, but what are we going to do a little bit better with specificity and isolation? What are we going to do now? We're going to get a medial hamstring in. How are we going to get the medial hamstring in? It's really quick. We're going to just talk about it. We're just going to put him in the very same position and just reorient that leg. And everything Pat just did, we do again. And now what he's going to feel is a little more sensory awareness of the medial hamstring. If I wanted both, I'd put both out there. But I'm a human working with a human, and therefore I'm going to assume until proven not guilty he is a human, which is why I'm not going to move this leg, and I'm going to go for more AFIR activity through FAIR positioning. That was a myokinematic discussion because I'm repositioning the muscle. Let's go to the next slide, okay? Let's go to the next one. 90-90 supported hip lift with a hemi bridge. This is one of my favorites. And Pat, let's read this one and we'll be done with these. And we'll have a little lab where you're actually going to do this. But we're going to finish this algorithm up, Joe. So let's go ahead. Pat, would you read this? Let's read this one, okay?
Lie on your back with your feet flat on a wall and your knees and hips bent at a 90-degree angle.
Check.
Inhale through your nose, and as you exhale through your mouth, perform a pelvic tilt so that your tailbone is raised slightly off the mat.
So I'm going to ask him to do that by starting to raise his knees up on exhalation. Okay? If you want to write that down. Next one, Pat.
Keep your low back.
And by the way, Pat, I'm doing this for Jen so she doesn't have to edit this. There's nothing wrong with me putting my hand under his tailbone and my hand here and helping him understand a posterior pelvic tilt. But if I have to do that, you have no business moving on. Do you understand that? If I have to physically help him figure out a posterior pelvic tilt, let's get that down. So I would say raise the knees up, let's get that going, press down on the floor, feel your heels, da-da-da-da. What we did the first time around, Pat. Now keep going, Pat.
Okay. Keep your low back flat on the mat. Do not press your feet flat into the wall. Instead, dig down with your heels.
This time it says, dig. Dig in the heels. Even if his toes come off the floor, I'm okay with that at this point. And Pat, keep going.
Maintain the pelvic tilt with your left leg on the wall and straighten your right leg.
So let's just dig on that wall. Come on up. Jelly belly it for me, Dallas. Keep your breathing going. You're doing a great job. Okay? And what do we want him to do right here?
Straighten the right leg.
Take the right foot. Are you ready for this? You okay?
Yep.
Don't puke on me. Okay? Take the right foot off the wall and straighten it. Perfect. Pat, perfect. I just inhibited his right hamstring and his button is just, do you feel it, Pat? I mean, do you feel it, Dallas? Go back to the wall because I'm afraid you're going to crumble. Go back down. Okay. I did my second inhibitory technique. I shut off his right hamstring. Can you write that down? I don't know if we really think about this. Got some experienced people in the room, but we got people that are going to watch this at home. I just inhibited his right hamstring, which means I had to facilitate which one? Without even telling him anything more, I inhibited the right, so he's got to feel the what? The left. You don't have to ask him to do anything more. Just straighten out the right. Done. And then, Pat, what's he going to do?
Slowly take your straight right leg on and off the wall as you breathe in through your nose and out through your mouth.
So he's just going to reciprocate movement on and off the wall at his speed, wherever he wants to do, as long as he doesn't move that left foot off the what? Wall. And we're going to watch him. If he starts to torque his body, Katie, he doesn't have whole control on which side now? The left. I'm taking all the work off the right and shifting it to the left. He's got to have stability on that left side. Let's see how he does, Pat. Is there anything else left on that technique?
You should feel the muscles behind your left thigh engage.
Okay. Here we go. Should we try it, Dallas? He will. The minute he picks that leg up, I'll take it out. So here he's going to do. We're going to leave it on until then. He's going to take a breath of air in, blow out all the air. He's going to dig his heels down. He's going to raise his knees up as he's blowing. Okay? Got it? All right. Go ahead and keep breathing. Take your right, do you feel a little bit of a lift? Got the dig going on? Now we're going to take the right foot off the wall. Good job. You're still doing it. Good job. Straighten it all further. Get it real straight. But I'm going to leave the ball there for now because it helped. He kept it. If he kept that ball up, what muscles is he working on the left side? His ischial what? Adductor. He's got it. Okay. Keep breathing. Do you feel that left hamstring? Do you feel the medial left hamstring?
Yep.
Now drop the ball. Do you feel all the hamstrings? All on the left side?
Yep.
Do you feel the medial hamstring? Squeeze the ball.
No.
Do you feel the medial?
Yeah.
Just depends on what you want. That's called myokinematics. Drop the ball.
Would he be kicking in the right adductor sometimes with that?
Yes, he will. That's why she said drop the ball. But you know what? I'm going to leave the ball in there for a while because I'm not working the right hamstring. I just inhibited it. And if I inhibit the right medial hamstring, which should be an adductor, because remember the semitendae, semimemby, and ischial adductor are all one group. If I just inhibited that hamstring on the medial side, he has no adductors on the right side working. I just want you to understand, ball between the legs are IR, bands around the legs are ER. Write that down. Balls between the legs are IR, it's myokinematics. Balls between the legs are IR, bands around legs are ER. So I'm going to use a ball. Until I'm convinced you know what you're doing, I'm going to use that ball. Thank you so much, Dallas. Have a seat. That was awesome. I appreciate it so much. That's called repositioning. Now, you will not hear me anyway tell you that the only repositioning technique is done in 90-90s. The best repositioning techniques are done in 90-90s for all the reasons Pat and I gave you, because all the reasons we gave you center around the word breathing, loose connective joints. That is the best repositioning. So you would do the best repositioning in a 90-90. On your side, on your back, in a chair, upright. Got a fly that loves me today. Are there any questions about repositioning as we went over it? Does repositioning include breathing? Sure it does, Brian. You know that. Does repositioning include inhibition? Has to. Does repositioning include internal rotation? You won't reposition anybody without rib internal rotation, without femoral internal rotation. Please don't chop that up. Rib internal rotation. Femoral internal rotation. Acetabular internal rotation is repositioning, because that's mid-stance. Boom. Let's go on to the next slide up here. That's ER. So I'm going to go back, and we're going to go back to that algorithm. Guys, thank you so much. We'll have a lab, and we'll go through all that. Are there any questions now where it says, as we go through this, it says reposition? Does anybody have any questions what that word means? Okay, good. Let's go to the next one. Now they can adduct. Do you see what I'm doing? I'm going, what page is that on, Sheila? You guys, 48? Now they can adduct. And it says, I want to make sure that they can give me an adduction lift score or an abduction lift score of 3 out of 5. Okay, so we would do those tests. You know what those tests are. They have a 3 out of 5, yes or no? Yes. They can adduct their leg, and they can now give me the 3 out of 5. Okay? We recheck. They can adduct their leg now because you just reposition them. We will have a lab for that. Okay? Can they adduct? Yes. Now, if they cannot adduct yet, did you see that next arrow? They cannot adduct yet. Underline, circle the word inhibition. We did not get Dallas to inhibit enough. Right, Drew? We didn't get him to inhibit enough. His left posterior capsule and his right adductor and his left TFL hasn't been dropped off enough. He hasn't been able to shift his A over his F enough on the left side. He hasn't been able to get his adductor shut off on the right enough. His TFL still thinks it's the queen bee. It doesn't know how to shut off. So the techniques we would use is something that would fit that left posterior capsule, that right adductor, that left TFL. So we would pick out a technique that would allow you to inhibit more. And I can almost tell you the technique. It's going to require a different shift. Not this shift, but that shift, where you shift a femur up into an acetabulum, and an acetabulum down on the right and up on the left is a different shift. So if you want to write that down, consider need for inhibition. That's a posterior capsule stretch. That's a left adductor engagement. That's a right TFL facilitatory activity. In other words, more flexion on the right, less extension on the right. More extension on the left, less flexion on the left. So any hip approximation, anything that's going to get a glute max on one side and an adductor on the other side, you could write in right now. We would show you those techniques. Can they adduct after that? No. We got to reassess the whole thing. Something else is holding them up. And there could be a myriad of things holding them up. Pelvic floor considerations. Before I go to the next slide. Postural respiration activities. Things that are going on with their rib cage. That's why you would take those other 2 courses. You'd reassess starting there. And then if you still can't get neutral, there's other things possibly going on. Some head trauma. Who knows? Some surgeries. Lots of things that we aren't going to be able to talk about in this class. If they can't give you an adduction lift score of 3 out of 5, I would go ahead and start standing, and so would the other 2 speakers, start standing unsupported PRI non-manual techniques. Jen's saying if they barely can get to 3 and you want to get them upright and you're at a 2, you'd probably keep them what, Jen? Supported. If they don't have a 3 out of 5, That's what Jen said. We'll keep you supported. We'll give you some things to do in a non-weight bearing or upright state to get you to figure out how to shift over to that left side. We would do that in a supported way with non-manual techniques. Non-weight bearing or standing supported non-manual techniques that result in a 3 out of 5 means you can play the game and go over to standing unsupported non-manual techniques. So you go back and you start doing some standing work. If they have no, you reassess that. Maybe they need some shoes. Because now you can't even get them to do standing stuff without something else going on. You're not going to go much further until you reassess it. Maybe you need to spend more time on what we did just this morning with Dallas. Maybe it's a breathing issue. Maybe they still don't even know what a posterior pelvic tilt really means. Maybe they don't even know how to pronate their foot. Maybe they don't even know how to get off their right lateral foot. There's other courses for that. If they have a 4 out of 5, then you start this thing called alternating activity. And the manual is full of that too. Alternating activity means you're going left, right, as they reciprocate with each. If they don't, you start standing unsupported, integrated, non-manual techniques, and you go back to getting them to appreciate left versus right. Now, that algorithm is new. It's just fairly new to this class. And we hope that it helps you make decisions on how to advance your patient. We hope that it gives you some guidance on how to start looking at a treatment program. Well, we're now going to go into patient A and patient B with respect to that algorithm. Who is patient A? Patient A is this: a person who has a positive adduction drop test on the left, coupled with a positive extension drop test. And what page are we on, Karina?
49.
We are on page 49 right now. Just checking, just make sure we're right. That's going to be our patient A today. That's the person that comes in that algorithm should work really well with. And let's go through that. That means these are the people that really like to live on which side, Sheila? The right side, okay? Their bicep femoris group on the left needs to be found for inhibitory purposes. Can you write that down? For inhibitory purposes. I'm trying to really clean this up. A bicep femoris that needs to be found for facilitatory purposes is not a PRI course. I thought about it all night long. Turning a bicep femoris on doesn't make you a special therapist or trainer. But turning a bicep femoris on the left side to inhibit patterns makes you a really good PRI therapist or trainer. Turning a hamstring on, anybody can do. Turning a hamstring on to get stronger, anybody can do. But if you don't turn that hamstring on without keeping off all the little, ghost flying around, things that are facilitated at the same time, only makes the pattern and the process what? More complex, more complicated. What's the second thing we're going to do once we get your hamstring to inhibit all the hip flexors? There were 4 of them. What's the second thing you got to do for this individual? You got to get this individual to start to appreciate how to move their body over to the left side, correct? Which hold control is going to do that, right or left? Right. You got to get that right hold control back. That right acetabulum is going to need, because you can't count on the left acetabulum. It hasn't been activated for years. It's got dust on it. Filters haven't even been working. And if you go over to the acetabulum on the left side and say, I'm going to pull you over to the left side, sure they will. Boom. And you're over there. They've been doing it that way for years. So to get you over to the left side, what do you got to use, Pat? The right obturator, foramen, the right acetabulum. And yesterday we talked about some muscles that really are good triosseous muscles to do that. Moving you over to which side? The left side. So number 2 and 3 says, I want my adductor magnus for my obturator Because remember, the red was right next to the green, the Christmas lights on that framing down there. That red and green, I want that red and green to work with ER activity. I don't want the red and green to work with IR activity. I want the red and green to work with ER activity. To get the red and green to work with ER activity, I better pull in my glute, what everybody? Max. Someone said, I asked, what did you learn today? And someone says, well, I'm starting to learn the importance of making sure that my glute max fires up. Mission accomplished for the day. So the right glute max and that hole control is going to be your second tier of activity. We're putting some pitons in the rock. We don't want to fall back. So if you stopped and did nothing but an activity program, Pat, that included right glute max right now, after you got somebody in the right position to do it, you're on your way. That may be the only thing that you need to do to save their day the rest of their life. Right glute max, left hamstring. Right glute max, left hamstring. With correct what? Breathing. Which is why you want to take those other two courses. Because those other two courses are pelvis breathing and diaphragmatic breathing. But if you get this done, it's going to be a lot easier to understand that. Because it's all about spinal regulation. And spinal rotation this morning was going to be done the correct way because there's 3 of them. 2 legs control that spine. You take the posture respiration course, they'd say, hey, go take that myokin course because you may have some problems below that don't allow you to breathe correctly because you don't own the floor. You don't have the glute max working on the right side on that floor on the left. Then we got a third tier of activity. We got to seal the deal with IR. God, we got to love IR. We got to love, look at those 3 IRs, 4, 5, and 6, underline 4, 5, and 6. And put down the word. Circle 4, 5, and 6 and say, look, IR. Circle 2 and 3 and write down ER. See what I'm doing to you, Katie? Now we're switching gears. If you want to be a great, great controller, you need IR, inhibition, and inhalation. Otherwise, the word isolation doesn't exist in your life. So we want to seal this deal with programs that are going to keep what muscle group on? Internal rotators that move the acetabulum on a femur in a state of transition. So when you transition over there, that IR is what? Going on at the same time. Not late, not early, but at the same smooth translatory time. Write that down. Same smooth translatory time of IR. Not choppy, not like shift IR or IR and shift. But it's all got to happen at the same time. That's called swing phase of gait on the contralateral side. You don't see runners doing this. Shift, IR. Oh, I'm sorry. You do. I'm having fun with you. They're choppy. They don't do it smooth. They shift, stay there, swing. They lose IR in the transition phase. Now, before I go any further, that is the program that we want to put a program together for. Sometimes you get some people that walk in your room with a little pathology. And the number one pathology of this individual you're working with, called a human, is going to be snapping, clicking, loose connected hip syndromes. And then you got patient B in front of you. Patient B has a problem. Their adduction drop test is positive on the left side, but their extension drop test, and it's in your manual, we're going to get to it. Their extension drop test is negative. And that would be on page 52. Everybody go to page 52. And I'm doing it right away. I want you to see it right away. So you got patient A and patient B. And the only differences that are on patient B is they've got this slop. They've got this pathological, they've got this myokinematic hierarchy of ipsilateral instability for the left AIC patient, secondary to pubifemoral iliofemoral, underline it, laxity. They're overly stretched out. Let's go back to the algorithm. Let's go back to this algorithm. Remember this algorithm? It says we need more posterior capsule because these people are not living in their posterior capsule. They're living in the anterior capsule. We need more adductor on the left side. They're not living with an adductor on the left side. They're living with an abductor on the left side. We need more, not TFL, anterior glute median, glute min. They're living on the TFL on the left side. They live that way. They operate that way. That's patient B. To get patient B, then, we got to get them inside that acetabulum a lot faster than patient A. We're going to rearrange the football schedule, the football. Last week, Nebraska was ranked number 15, I believe. The week before that, they were in the cloud somewhere. We're going to rearrange where you are on that chart. We're going to move IR up. If I do my math correctly on 52, I see the IR group just jump ahead of the ER group this week. They must have beat a few people out last week. You see that, Sheila? The IR group on page 52 bypassed the ER group. This week, the IR group's ahead of the ER week. You see that, Pat? But everything's the same. Because we got to make sure you can get on top of that femur. And then we'll do some ER work. We're not going to wait for the glute max right away. We're going to go right into IR. We got to get you to feel IR, sense IR, breathe IR. We got to have IR. Because if you don't have IR, you're going to be back out there in that anterior capsule. You won't know how to get it. I don't need to say much more about that. That's patient B. So, some of the same techniques you would use for patient A, you're going to do in patient B, but what's the difference? You're going to do them a little bit what? Earlier or later, depending upon what we're talking about. And that's the rest of the course. How do you treat these two patients? Using the algorithm that we just went over and using these two cases as we did. One today is more important than the other because of how you present it. Then there's those people that are kind of like in purgatory. They're kind of hanging around. You know, one day they're in and some days they're out. You know who they are? They're just kind of floating around. I don't know where my soul's going to go yet. Can you help me? Those people, you should go right to page 52. Because they're already showing signs of instability. Here's a trick question. Do those people that I just talked about and the patient B patients need more inhibition or less inhibition? This is a trick question. They need as much inhibition as you possibly can give these sinners. Do you follow me? They need as much inhibition as you can give them. Because if you dare facilitate anything, they will pop right out. You understand that, Brian? They need as much inhibitory processing as you can give them. And that's going to be tricky. Because we are going to inhibit like no other one muscle, this TFL, big time. So, Katie, these people have got one thing on their mind. Hip extension like no other. With what? IR or ER? IR. Can you say a program of medial hamstrings? It's not even ischiocondylar adductor at this time. Can you say a program of anterior glute median min? That's what you're going to see because the IRs moved ahead of the ERs on that list. And I hope that discussion this morning made some sense. I really wanted that on tape. As the director of the Institute, I want that on tape. Because what's going to carry this program down the road another 100 years is that discussion right there. Because if you don't have that discussion, it's going to fade off. With that being said, we're going to go through, and now we're going to go back to that patient A, and we're going to start with patient A, and we're going to show you what techniques to use to get that person in the right. Remember what activity we're going to do? We already showed Dallas how to reposition. What's next on Eric on the chop block? A group of IR, ER activity? ER. ER activity. These are the people that walk in. They're not really too pathologic. Their bursitis are talking to them in the hips. Circle right SI. Right SI. If you see a right SI patient, you got a patient A. And if you look ahead in the chart, if you got a left SI, you got a patient B. There are people that have tibial stress fractures, shin splints, hip impingement syndromes. We teach an I&I course on most of those. Pubalgia, hamstring pulls, circle it, circle it, circle it. Bobby, I guarantee you in the Army, you're going to see hamstring pulls. Are you ready for this? You're going to see lots of hamstring pulls because I work with those guys. Lots of them. And they're going to be mild, moderate, and severe strains. And there will be a lot of them. And anterior knee pain, it's a given. So on either side, okay. Pat, you were so kind that you actually did some reading, and I'm going to ask you for some help right now. Pat, which one of those four would you like us to actually go to the appendix, pull out, and read? Which one of those four would you like to do?
Actually, C.
Oh, okay. Let's do C. Now, Pat is we're going to go ahead and have Pat experience C. Dallas, you're going to read it, okay? So page 36, Dallas. See, tide turns around, Pat. Okay, Dallas, on page 36, are you there? You're going to tell Pat what to do because she really wants to feel C. Now, she could have picked any one of those. Before we get her up here, let's look at all the common characteristics of these four. First of all, Jen, are there more than four? Oh my gosh. I don't even know how many glute max activities we have. But every single one of these evolve around AFIR on the left with either AFER or FAER on the right.
Or both.
What's that?
So or both of those on the right.
Or both. Thank you, Jen. Or both. AF or FAER or both on the right. But they all are going to have you in a state of what? AFIR on the left. Let's look at the AFIR on the left first. How did this person get into AFIR on the left? This is a snippet. We are not going to go to the page because you didn't pick this one, Pat. If I would have said, move, before you take this right leg out into ER, move this left knee back. Well, in that supine hook lying position, might you have AFIR on the left? I might get acetabular femoral internal rotation if I move the right knee forward and the left knee back, okay? Over here, if I move her right knee forward, this is a snippet, and the left knee back, or if I push into the left hip into the mat I'm laying on, I would get AFIR established for AFER on my, or FA or AFER on my right side. Does this move the spine? Does this move the spine to the left? And does this rotate the spine to the left? Yes. Every one of these has the spine moving to the left simultaneously with rotation of the spine to the left. Probably should write that down. Another myokinematic moment of life. Every one of these has the spine moving to the left in a frontal plane. At the same time, it's rotating to the left, Bobby, in a transverse plane. Isn't that cool? That's the antithesis of a spine that's moving to the right in the frontal plane and that's oriented to the right in the transverse plane, called the human pattern. Every single one of those. Ball between knees turns on adductors and internal rotators. Band around knees turns on abductors and external rotators. I see abduction going through the right, you're picking it, with external rotation on the right to move your spine and pelvis to the left with complementary IR. That's what I see. I'll see the same thing. Drew, did that help? Dallas, you ready to read it? All right, come on up. Dallas, what's the first sentence say?
Stand against the desk or counter and place your right foot on a 2-inch block.
I just need somebody to go in the library and get me an 1 or 2 inch block. Is someone doing it? Okay, we're on it. Come on up here. We'll pretend like you're in a block, okay? Yep. Hold on just a minute. Let's get the block. Let's do it right. You're going to face that way. Yeah, we're going to face that way. And you pick C. Right, nice job, Pat. You picked a good one. I thought we had a block up here. So let's read while we're waiting. Let's keep reading.
Place your hands on the surface in front of you and round your back.
Okay, so you're going to go ahead and put this 1 to 2 inch block under your right leg, okay? And you're going to put your hands on that mat. And I'm going to round you out, and I want you just to stay there. Pat, microphone, I'll get close to her, Don. Just feel that. Just look straight ahead and feel that, okay? Where do you feel the center of your mass right now? Is it on the left leg or the right leg?
It's center and left.
Okay, it's on the left leg, right? Mm-hmm. So that's where it should be. Do you feel the left? Do you feel the left hip over here?
I do.
Okay, perfect. Do you feel that there's a difference in the two floors?
Yes.
Floor right. Where's floor right? Is it below or above floor left?
It is above.
I'm asking my patient to tell me that. Because here's what they're going to say. I don't know.
I feel floaty on the right side.
Okay? You guys understand? They're going to say, I don't know. I don't know what floor right and floor. I mean, I feel like I'm on both floors. They're going to feel like they're leveled to some of these patients. And some of these patients will say, I feel my left foot's right now higher than my right. What are you going to do with that person? Shoot them, or what are you going to do? What are you going to do with that person? Okay? You understand, Karina? You're going to have these people like that. Okay? Then what you ask them to do, what'd you ask them to do, Dallas?
Maintain.
Second
thing.
sentence.
Place your hand on the surface in front of you.
She did a great job of that. She's a listener. She's got that. Third, what's the next one?
Maintaining contact on your right arch, begin to straighten your right knee as you raise your left foot off of the floor.
Well written. So what I want you to do is feel your entire right foot. Okay. Can you turn your right foot in a little bit and feel that arch too?
Yes.
There, you got it? Mm-hmm. Don't lose that arch. Don't lose the foot. Got more foot over there now?
Yes.
Than you had before? Mm-hmm. Start to straighten your right knee. Good. Now what, Dallas?
Keeping your left leg straight, hike your left hip up above the level of your right as you side bend your trunk to the left.
So very good. Just keep more pressure on this left hand. You did it, Pat. And lift that baby up. Got it, Pat?
Yep.
Whoa. Hold it right there. Pat, got it? What's the next one, Dallas?
Keeping your left hip hiked, slowly begin to lower your left foot toward the floor by bending your right knee.
Don't move your pelvis. Wait a minute. I got my super glue gun. Super glued, dry. Super glued, dry. That's super glued up. You can't move it. Got it? Yep. Don't move it. Breaks, done. Got to start over. Bend your right knee only. Nice. Pull it back up. It's like pulling a boot out of mud. I was going to say something else, but I'll leave it at that. Pull a boot out of mud. Pull the boot out of mud some more. Pull it up. Pull that boot out of mud. Pull it up, pull it up, pull it up. Do you feel the left inside thigh?
Yes.
Do you feel the right outside hip?
Absolutely.
Point to what you feel on the right. Where is it working on the right?
All the way up.
Do you feel your right glute max?
No.
Okay, then pull your left. Then let's go ahead and pull it. Now do you feel your right glute max?
Yes.
Do you feel, point to what you feel on the right side now.
It's all.
How did she find her right glute max? I had to inhibit the left glute max. How did I inhibit the left glute max? Did I say, give me more right glute max? I said, pull what? The boot way out of that mud, which is what muscle? The ischiocondylar adductor. Take a break. I didn't do more facilitatory activity. I did more inhibitory activity. I didn't tell her to turn on her glute max. I said, do you find it? She said, no, I don't have it. Well, then I know I don't have enough inhibitory activity. Which glute max is still working too hard? And which posterior capsule can she not get in as a result of that? The left, 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 left. Go back to your algorithm. She selected the technique. She wants to know what that feels like. It feels different now, doesn't it?
Yes.
What does the floor feel like? Put your hands back on the, no, stay where you're at.
Yeah.
Now what does that floor feel like?
I can feel it more.
You see how we're just giving you more and more? Because you said you felt floaty.
I did on the right side.
Do you feel floaty right now? Because she's just found her glute max. Did you see how I went through this, Eric? I didn't just pop her up here and say, could you pull the left leg up, feel your right glute max? I didn't do that. I said, you tell me what you feel. You tell me, did you feel your quad kick in? Sure she did, but I didn't ask her that. I said, straighten your right knee up. Thank you for your help. Is there anything we missed on that technique?
Just breathing.
Okay. Just breathing, he said. This is what I always love. Cheers, everybody. Just breathing. Dallas, do you understand what you just did for everybody? Because I guarantee you a few minutes of not breathing and she's going to feel her back. Just a little point called what, everybody? Breathing. And I am slowing down, having a cup of coffee over that one. That made that a PRI activity if you just what? That did not make it a PRI activity if you forgot that last step. Could you show the whole thing for us again on camera? And we'll be done. Show us the whole thing. She did a great job. Do you feel your right glute max?
Yes.
Do you feel the inside of your proximal inner thigh?
Yes.
Do you feel your foot being pushed down on a floor that's coming up on the right side?
Yes.
Do you sense the floor coming up on the right side? Do you feel your center of mass shift to which side?
Right.
Very good. Do you feel that you have more contact with the mat by the left hand or the right hand?
Left.
Very good. Can you find more for me? There. Do you feel that contact?
Yes.
What happened to the floor on the right side?
It left.
It came up even more. Are you breathing for me, Pat?
I will now.
Okay. Breathe 3 or 4 times in and out. And every time she breathes, she's going to feel her left hand now on inhalation go to the mat. Is that correct, Pat?
Yes.
And every time she blows, she's going to feel her right glute max on the right side. Correct, Matt? So every time you breathe, did you feel the mat come up on the left side?
Yes.
Every time you blow out, did you feel the foot come up on the right side?
Yes.
You're a perfect patient. Have a seat. And for the home video people, replay that 3 or 4 times. She picked a good technique. Did that make sense to everybody in the room, what we just did? Feel a little different, Pat?
My hips feel way better.
Okay, so that's where we're at with that particular technique. Okay, let's go to the next one. Adductor magnus on the right side, or adductor magnus, on the right side. Left side lying supported right glute max. Left side supporting right glute max. Standing wall supported left knee flexion with resisted right glute max. Everybody circle on what page are we on? Karina? What page are we on with this right now?
50.
We're on page 50. Everybody take your pencils and pens and circle glute max on all 3. Circle glute max, but it says adductor magnus. I thought we were in the adductor magnus group. Well, you are, but I'm not going to let you get the adductor magnus without what muscle? Glute max. Circle it, Dallas. Every single one of those has a glute max, which means your adductor on the right side no longer is doing internal rotation. Your adductor on the right side is now in only what? External rotator. Isn't that what we really want, Chad? Don't we want external rotation adductors on the right side? Because they've been breathing and living with adductors that are what on the right side? Humans? Internal rotators. But Dallas, I want an adductor group that's an external rotator. And we have lots of examples we have lots of research that say adductors can change myokinematically and become IRs or ERs depending what co-activation of muscle go on with them. Do you want an IR for an adductor or an ER for an adductor? It just depends on what you co-activate them with. If I want a glute max going with my adductor magnus, it's going to become a muscle of what? ER. If I want an IR, I would put something with it for IR. I'd put you in a different position with IR, and it would now become a better IR muscle. But on this side, we want the adductor magnus to become an ER muscle. What do we want the ischiocondylar adductor on the left side to simultaneously become? An IR adductor. So we have 3 of those. Let's take one more example. Let's pick on somebody different this time. Let's pick on Chad. You're never picked on. Chad, pick one of those. Which one of those would you like to do?
B.
You like to do B. Lydia, you're going to read B on page 35, okay? We're going to B on page 35. We're going to see if we can get his glute max and his adductor on the right side to work, okay? For whole control on the right side so he can move and transition his hip to which side? The left side. Okay, so got it, Lydia? What page is that? 35? Come on up here. Is he in a 99 position right now? Yes. He's in a 90-90 position. This foot's not in a 99 position, but he starts off in a what, everybody? A 90. Picked a great technique. Already he's got the capability of doing transitory transition activity. Let's look at all 3. Are all 3 of those kind of in a 99 position? Almost all of them are. The bottom one's not quite, okay? So he's got, Lydia, what does it say?
Lie on your left side with your left hip and knee bent at 90-degree angle.
That's a 90-90. Done deal. Got it. What's next, Lydia?
Keep your right hip neutral, aligned with your body, and place your right lower leg on several pillows or an appropriate size bolster.
And that's coming, okay? Check. What's next?
Your right knee will also be at 90-degree angle.
Check. Keep going. The right knee would be at a 90-degree angle. Is the right hip at that point in extension? Anybody can answer that question. No. It's in neutrality. Okay, keep going.
Press your left foot into the wall and press your right knee into the wall.
Okay, so by pressing the right knee into the wall, which hole is he going to get controlled? By pressing the right knee into the wall, he'll get hole control on which side? Nice job. So now we're not putting the foot in the wall, we're pressing the knee into the wall to get hole control on the right side. Correct, everybody? So Lydia, thanks, Jen. So we got this guy in hole control on the right side because, here's 2 pillows for you too. Just throw it on the floor. He's got his right leg. You have to get closer now. Okay, you're fine. I'll take it. You know what I'm going to do? I really want to keep using that. So we'll put some towels there. You know what? I'm going to use a bolster because you got, I didn't realize your femurs were that short, Chad. You got short little femurs. Did you know you had short? Of course you did. Okay, so here we go. Good. Feel that? Okay. Foot's on the wall, knees on the wall. What are we going to do now?
Maintain the above position and rotate your right thigh outwards towards the sun.
Okay, so he's going to take that right leg. I'm going to have to push it back now, Chad, a little bit. Lift up a little bit for me. There. Okay, and he's going to bring this hip forward. He's pushed this foot in the wall. Put this hand right here. Keep this hip on. And now he's going to take his right leg and do what with it?
And rotate it.
Up in my hand. Okay, keep going, keep going, keep going, stop. Okay, so that's external what, everybody? Rotation. Got it? Tighten it up. Good. Hold it. Go back on down. Now, push your foot pretty firm in the wall. Did you? Got it. Take this leg up. Good. Now, I feel bad because he really should have this foot on this bolster, so I'm going to move him closer. We would normally do this on the floor or a mat that's bigger, but we're going to keep him up here for the camera. So he's going to come closer to me. Keep a little, there, a little closer. Now, let's bring this foot there. Did you see what I did? And there, push there. Got it. Did you see how that helped? Now keep that butt on, push in the wall, push your hip down by taking this knee and externally rotating using that ankle. Do you feel that, Chad? Did that help a little bit? Good. Do you have your glute max on?
Yeah.
Do you feel anything in the adductor on the right side?
No.
Okay, so push down with this left foot. Now, push this knee into this bolster if you can. And now lift the knee up if you can. And push the heel down if you can. And I know you're externally rotating. Yeah. Do you have anything in the adductor yet? Now bring this knee up a little bit. How about now? So now I'm kicking this adductor in by facilitating this adductor, raising it up. Ball between the knees is what, everybody? Internal rotation, adduction. I got this one going on. He's in external rotation on the side, but he's still got to keep this leg coming up. His pube is being pulled to the left. He's balancing it out with an adductor on the right. His spine is completely neutral. This is running. He's in there, he's running. He's about ready to clear a hurdle. You see it? And you want to take a rest. Let's go through the checklist. Did you have your right glute max?
Yes.
Did you have your left hamstring?
Yeah.
Did you have some adductor magnus on the right side?
Yeah.
Did you feel like your back was tensing up?
No.
That's called inhibition. Now, honestly, I like it, Dallas, because most people wouldn't have picked that one. But I love that technique for this particular example. What did we just do to his spine? Just someone tell me. Did we push it to the left or the right? Yes. Did we rotate to the left or the right? Yes. We pushed it to the left, we rotated to the left. We started to get more, we got more AFIR out of his left through right AFER by using not this hamstring, by using this hamstring. We did have to have him really, his leg isn't long enough, so I had to put something here. I could have got a shorter, some pillows here, put them on the floor and took this away, because this kind of interfered with it. But once I gave him a pivotal point to turn, he could engage his glute what? Max. Quite honestly, guys, this is a repositioning technique and a number 2. Remember the 3 tiers? Reposition, right glute max, right adductor magnus, right glute max, and then what's the last 3 say? Internal rotation on which side? The left. This kills both 1 and 2 in a heartbeat because he's got his 90-90 right here through this left leg. He's doing a Henry bridge on which side? His left leg. So he's killing number 1 and 2 with 1 pick. Picked a good one. Do you have a question, Karina?
Yeah, when he reaches for the wall with the right knee, do you see extension of the back sometimes when he...
Well, he would if I didn't put this bolster there.
Okay, because
And-
that's what I was trying. How do you keep, do the reach and lift without engaging?
That knee should be on that wall, but I can't, I'd have to put him on the floor to do it. And we have a ledge on this floor, and I just want to get him upright for the camera. So I had to put this here as his wall. Because if he doesn't get this to the wall, he doesn't have hold control. And your back's killing you right now. Are there any other questions? Do you want to add anything, Chad? That was a great pick. Do you want to add anything at all? Chad, honestly, do you do this quite a bit? Or do you do this at all?
Never.
Thank you. I want him to be honest.
Just for the camera view, because I'm standing here watching it, his right hip's in a flex position.
Yeah, we're not in
Only
active.
because we don't have enough room on that side of the mat to get him into a completely neutral position.
We're on a narrow mat. But he's not laying here for the camera active right now. He's just laying here. This is how it would look. Can you do one more? That's how it would look. Right? Y'all see that? That glute is now on, isn't it? Now go ahead and push. Lift a little bit. Thank you. Now pivot. There. Glute max.
Yes.
Some adductor.
Yeah.
Some hamstring. Are you breathing? He's sweating. Thank you very much. 3 or 4 breaths, what does it say? Who read this one? Lydia, how many times?
4 times.
4 breaths, in and out. Just for kicks, why don't we breathe? Okay? Thanks, Chad. Thank you very much. Okay, we're in a good position to stop right there. We got down, we got one more tier left for this. We'll come back after lunch. You guys were awesome. Are there any questions? Anybody have any questions? Okay? All right.